Right, so welcome everybody. Hopefully I've spotlighted myself and you're looking at me again, sorry about that. So welcome to the Innovations in Social Prescribing session. I think you've got really good online etiquette here of muting yourselves and everything when you come in, and you can have your camera on off. Oh, I've just seen Julia Briscoe, who I haven't seen for a long time, so hi Julia. So we've got 5 presentations for you, and what we're going to do is share screen and run through them, and then do quite a bit of Q&A at the end. So you've got we're going to see 5-minute bursts of innovation, and then we'll have hopefully nearly half the session for Q&A. So do put your questions in. I'm going to keep a look on the questions, and we'll pull some out, but speakers, you can also look at the questions, and if you want to answer them directly, then please feel very free to do that as well. And we've got some great people. Just look at all the names coming in, it's fantastic. So just keep yourselves on mute, that'll be fantastic. So the first presentation is by Elizabeth, now is it Helitzer? I hope I've got that right. And this is about singing on social prescription.
Oh, you've gone on mute. Not sure why.
Sorry about that, I don't know why it went on mute. Anyway, so the first presentation is by Elizabeth Helitzer, singing on social prescription in Ireland, which is going to be fantastic. And I think at the beginning, Elizabeth introduces herself anyway. So Siân, would you like to play the first presentation for me, please?
Thank you to the co-chairs, Dr. Marie Polley and Siân Brand, for the introduction, and to the conference organizers for including us in this wonderful event. My name is Liz Helitzer, and I'm a PhD candidate at the University of Limerick's Irish World Academy of Music and Dance in Ireland. Dr. Hilary Moss, my PhD supervisor, is also involved in the research I'll be discussing. Singing on social prescription in Ireland, my topic for today, is connected to my PhD, Singing for Health and Well-Being, an exploration of singing on social prescription in Ireland. There's a growing body of evidence supporting the many benefits of group singing for one's health and well-being, such as improvement in mental health, social functioning, and community engagement, as well as practical impacts like development of a routine. Similarly, positive, practical, personal, and social shifts have been amongst the benefits noted by individuals who participate in arts on prescription, which is a branch of social prescribing. My project aims to catalog and map all singing for health and well-being opportunities in Ireland, determine whether service users are ever advised to avail of singing through social prescription, and explore the feasibility of integrating singing on social prescription more widely into mainstream health policy. The first phase of my research looks to address the following research question. What is the context in which singing groups with the explicit aim of impacting health and well-being are occurring in Ireland? To answer this question, we're creating the first ever national map of singing groups in Ireland with a health and/or well-being remit. Qualitative and quantitative data collection is taking place through an electronic survey and is still ongoing. In addition to collecting demographic information, the survey includes such questions as, is this singing group open to any member of the community, or does it target a specific population? If a specific population is targeted, how would you describe that population? Since COVID, the singing group no longer meets or meets in a different way. And how have group members learned about this opportunity? Most pertinent to the topic at hand are the first 2 options: referral from healthcare professional, i.e. social prescription, GP, mental health professional, or referral from community link worker, i.e. social prescribing coordinator, community health worker, community volunteer. A matrix is also included asking respondents to indicate which of the following aims are priorities for the group: a professional level of artistic production, singers' general well-being, singers' health, socialization of singers, social integration, singing for pleasure or leisure, producing public concerts, or other. To date, the survey's been distributed electronically through Sing Ireland, which is the Choir Association of Ireland, and artsandhealth.ie. Stakeholders with potential links to Singing for Health and Wellbeing have also been contacted, such as social prescribing coordinators, county council arts officers, and community music and art centers, among others. At present, 166 individuals have responded. Following deduplication, 141 Singing for Health and Wellbeing groups have been identified within the Republic of Ireland, 6 of which are virtual-only concerts, and there are 4 additional choirs in Northern Ireland who have also responded. This map identifies the total number of Singing for Health and Wellbeing groups by county. Each county is represented by a different color, and the number represents the total number of Singing for Health and Wellbeing groups in that county. So for instance, Dublin is in light red, and there are at least 31 Singing for Health and Wellbeing groups based in that county. I've presented the same data in this bar graph, and you can see that 11 counties, including Carlow, Cavan, and Leitrim, only have 1 or 2 Singing for Health and Wellbeing groups. Of the 141 choirs, 31 noted that at least one source of choir recruitment was linked to social prescribing. Specifically, referrals came from a healthcare professional or a community link worker. The number of groups with a link to social prescription is indicated by color. So for instance, green indicates a county with at least one instance of singing on social prescription. The 15 counties in blue have yet to indicate any instances of singing on social prescription, highlighting a potential gap in provision. Additionally, 2 virtual choirs and 2 choirs in Northern Ireland, not pictured, also noted links to social prescription. Our aim is to continue adding to the map of Singing for Health and Wellbeing groups and to the map of Singing for Health and Wellbeing groups with links to social prescribing. Ultimately, we want to publish a living interactive map that can be utilized by individuals interested in group singing for health and well-being, as well as by social prescribers. So we would love your help with this project. If you or someone you know is involved with a singing group that has a health and/or well-being remit, please feel free to reach out. We're also in the midst of conducting a scoping review, looking at the research question, what is the evidence of singing on social prescription internationally? If you're aware of any literature about singing on social prescription, we'd be grateful for your input. We're very eager to collaborate. I'll now hand it back over to Dr. Marie Polley and Sean Brand and happily answer any questions. Thank you.
Thank you very much, Elizabeth. A really neat presentation there. Nice to hear something from Ireland as well. I can see that we've got Denny Wolf on, and I know Denny's put some stuff together for us in other sessions, and I know that Denny's Carnegie Hall, and there are certainly music and lullaby projects that we'll be closing the conference with, so I think there's a connection there already. So welcome to people that joined the session just after we started the first video. We are going to run through the 5 innovative videos, and then we're going to do question and answer afterwards. If you have a question, then do put it into the chat. That would be fantastic. So we're going to move on to the next one now, and now for something completely different. So the next presentation is by Jason Scott, and this is called Why Always Primary Care? Exploring the potential for social prescribing in pre-hospital emergency and urgent care. And this actually is Jason Scott, Gail Fiddler, Daniel Monk, Darren Flynn, Emily Heavey, and they represent Northumbria University, North East Ambulance Service NHS Foundation Trust, which is a mouthful, Teesside University and the University of Huddersfield, so a really great collaborative project. So, Sean, over to you to play, and I shall unspotlight myself.
Thank you very much for the introduction. Today, I'd like to pose the question of why always primary care in relation to social prescribing. And I want to specifically talk about a research project that we've just finished that's looking at the potential for social prescribing within a pre-hospital emergency and urgent care setting. So I'd first of all like to start off by thanking North East Ambulance Service for funding this research, as well as my colleagues Gail Fiddler, Daniel Monk, Darren Flynn, and Emily Heavey. And if you would like to see more about this research in particular, the manuscript of a point-down recording of this presentation has just been accepted for publication in Health and Social Care in the Community. So please do go read it. So first of all, I'd just like to start off presenting this excellent piece of research by Karen Husk that essentially models how social prescribing currently looks. And you can see here, we've got primary care right at the outset. And this is a question, and it leads to the overall question of the presentation of why does this always have to be in primary care? So for instance, we know that within ambulance services, that a lot of patients will access, whether it's NHS 111, it's quite often but not always delivered by ambulance services, or for 999, that people use ambulance services for essentially what's referred to as primary care problems. So problems that they could be accessing primary care for, but don't. So they're using another avenue to access healthcare services. So what we wanted to do was to set out and just try and develop a bit of a better understanding of the role that social prescribing can play within pre-hospital either emergency, so 999, or urgent care services, in other words, 111 services. And to do this, the specific objectives were to determine awareness of social prescribing amongst relevant clinicians, identify potential cohorts that would be suitable for social prescribing, and also to explore any potential barriers and enablers of doing so as well. So, I'm not going to read through the quotes, by the way. Feel free to pause the presentation and have a look at them and read them in your own time. And also, please do go read the paper, which has a lot more quotes in it. Essentially, the findings from our study were that the suitable cohorts were identified were that the patients with mental health conditions who were using the services, who could potentially be suitable for social prescribing, as well as people who are lonely and or socially isolated. And within both of these categories, participants frequently told us that this would involve the likes of older people, as well as people who frequently call the ambulance service. In terms of the determinants of social prescribing, what we found is that we could look at these across the micro, meso, and the macro levels. So to start off at the micro level, what we found was essentially this would come down to acceptability. And we know that this is an issue with social prescribing in general, about whether patients will be accepting of it, but also whether staff will be as well. So this was the first determinant. Can we get over this problem of patients accepting, so patients who are calling 999 and 111 might expect a specific outcome, such as an ambulance to convey them to hospital, but we know that that's not always the case. So can we get patients and staff to accept social prescribing? This is the first one. At the meso level, we have awareness of services and the referral pathways as well. So with ambulance services, they deliver across very large geographical areas, much larger than primary care, or some primary care surgeries might do, or GP surgeries. And so therefore, you might have somebody who's got a little bit of local knowledge from where they're from, but you could have somebody calling, say, for instance, from Northumberland borders, northeast of England, and you might have a clinician who's from Middlesbrough, about 100 miles away, and so they wouldn't know what services were available that are local to the patient. So there's awareness of services, but also exactly how you go about making those referrals was another challenge too. And finally, at the macro level, was the commissioning and the funding determinants to this. How do we go about funding social prescribing services for people who are accessing 999, 111? For instance, how does this fit into the existing primary care networks and the existing link workers as well? And so these are all sort of questions that still need to be addressed. So to conclude, and I know that I've gone through this very quickly, but to conclude, what we would say is that pre-hospital urgent emergency care services, they are currently managing these primary care sensitive problems, and therefore they should be able to utilize primary care solutions, in other words, social prescribing. There's also a pressing need to develop, pilot and evaluate systems to support staff to socially prescribe, whether through triage systems or clinical referral. We also need to address these determinants of social prescribing that have been identified, particularly where there's these large geographical areas and also multiple commissioners. And finally, to answer that question that I posed right at the start of why always primary care, I would actually propose there's an alternative to this, which is that yes, primary care can be the primary point of access for social prescribing, but 999 111 can provide an alternative for patients who don't access primary care. And it's otherwise a potentially lost opportunity. But I'm more than happy to have this debate with people if you would like. And so with that, please feel free to contact me if you've got any questions or would like to talk about this further, or would even be interested in collaborating in the future. And also, please do have a read of the paper. It explains all of the methods in far more detail. But thank you very much for listening.
Thank you very much, Jason. I think it's fantastic to hear social prescribing and how it's being used in the ambulance service. And I've heard of a few examples now, and it's been really successful. So I think to understand what the sort of the challenges are as well is really important. I think that links into a lot of the discussions of the conference today. So again, if people have joined whilst that presentation was on, we've just had our second presentation. These are very diverse presentations today. We're going to start our third in a moment, and we are going to do question and answer when we've done all 5 presentations, because that allows that to flow a bit more. So I want to move on to the third project. So we've been to Ireland, we've been to the northeast of England, and we're going to go over to Australia now. And this is a presentation using Makeshift, which is a creativity on prescription 8-week programme for injured workers. And this is presented by Caitlin Marshall. So really looking forward to this. So Sean, are you able to share that presentation for us, please?
Hello, my name is Caitlin Marshall, and I'd like to thank the conference organisers for introducing me and for the opportunity to share with you about my work in social prescribing. I'm a social worker and a social prescribing facilitator based in Wollongong in New South Wales, Australia. Before I continue, I do want to acknowledge the traditional owners of the land I live and work on, which is the Wadi Wadi people of the Darul Nation here in Wollongong, an hour south of Sydney. And I want to pay my respects to elders past, present and emerging. So I'm the co-founder of Makeshift, a social and creative prescribing organisation. We've been working for about 8 years and only quite recently formalised talking about what we do as creative and social prescribing. I'm going to share with you today a little bit about our pilot project working with injured workers on a workers' compensation claim. And the evaluation and outcomes that have gone with that. So I will just share my screen. So we developed and designed an 8-week program called Creativity on Prescription, which is designed to give people an opportunity to explore hands-on creative practices that have an evidence base for supporting mental health and self-care and self-regulation strategies for alleviating symptoms of trauma, PTSD, anxiety and depression. We had the opportunity to work and partner with ICARE New South Wales, the state government workers' compensation insurance agency, to engage participants on psychological injury claims. So ICARE really identified that psych injury claims are often very hard to engage people in the recovery process of, and that the claims process itself can exacerbate the existing or initial injury. So our program, which we understand is maybe there isn't another one like it in Australia, we might be wrong, whereby we're using professional artists to share their practice as a way to engage in fun, delightful, joyful, pleasurable, return to life activities that humans are hardwired to do, but many of us have been given the message that we're not good at them and therefore we shouldn't do them. Our program's designed to really educate people around why they're good for us, So while we experience a session on drawing, our participants also learn what happens physiologically and psychologically when we draw, understanding that it reduces our stress hormones, it promotes a sense of mindfulness that can really help in developing ongoing and sustainable self-care day to day. In working with people on workers' compensation, the landscape is, I believe, quite similar to the UK, where psych injury claims cost about 3 times the amount as a physical injury claim. People are usually off work for about 3 times the amount of time. I think a physical injury average length is about 12 weeks. We've worked with people who have been off work for over 2 years, some over 5 years, and some are medically retired, as well as people who are just on a claim as well. Predominantly, the participants in our program, so our pilot is funded to deliver 4 8-week programs with up to 15 injured workers, and we've just started our 4th yesterday. And they're predominantly from first responder workforces, so police, paramedics, nurses. We've also had quite a few people from the education system. You know, typically police, particularly with, you know, the vast majority have had a cumulative build-up over time that's resulted in a PTSD diagnosis, and they're typically labelled as the too hard basket or too hard to engage. We've had really great rates of retention in our programs and have a waiting list ongoing for our program. So our program involves people being delivered a creative first aid kit to their house. It includes a ukulele, paints, a seedling kit, a cooking kit, craft, drawing materials. And then we meet once a week on Zoom. We bring in a creative facilitator to teach us a practice. We spend time immersing in that individually and then come back to debrief and really understand how that practice can form part of an ongoing self-care strategy. It also brings in psychoeducation tools for people to start to understand and recognise symptoms on a day-to-day level so that they can begin having an awareness of what they need to manage it. This is a very quick overview of what we cover in our program. And all of these practices have come with some evidence research base behind them. Our evaluation framework has been designed by an academic researcher from the School of Medicine at University of Wollongong, Dr. Pippa Burns. And she's brought in tools that are aligned with a lot of the social prescribing initiatives happening in the UK. And we do a pre and post program survey as well as a pre and post session check-in as well. And some of the outcomes that we're seeing, obviously our pilot isn't complete yet, but have been remarkably positive. We've seen 75% of participants tell us they learned to recognise their moods and found they could change their mood using the strategies they learnt in our program. Over 75% of our participants feel more hopeful about the future. And, you know, another thing that's not written here, but another learning we've really had from our participants is that at the end of our program, they feel a lot more ready and have more capacity to keep engaging in more formal treatment for their trauma recovery. I'm just going to be super quick so I don't take up too much extra time, but our snapshot is really showing through our evaluation that there is significant change as people go through the program. So people identifying as having severe anxiety or depression before has, after the program, drops to 16%. The social contact with others also increases significantly, which is a huge part of what we see as the role of creative practices in being a great platform for people to then base social connections around. We'd love to share with you the final results of our full pilot evaluation once it's all collated. It'll be on our website, which is makeshift.org.au. So what we're seeing overall, and the feedback not just from participants, injured workers, but also insurance claim agents and their referrers, such as clinical psychologists, is that this social prescribing creative prescription program model is having significant impact on injured workers with a psych injury, unlike other interventions and options. We describe it as a return to life program, and we are committed to empowering people to develop their own understanding of their symptoms, and what strategies work to connect them back to joy, delight, and play in life. Thank you so much for listening. I'm really grateful for this opportunity, and I'd love to hear from any of you. You can contact me on caitlin@makeshift.org.au. Thank you so much to the conference organisers and the rest of the panel, and I'll hand it back to you now. Thank you.
It's a really fantastic presentation from Caitlin. I think it's really interesting to see frontline responders actually getting some therapy themselves and social prescription. I think there's going to be a lot more of that needed as people come out of responding to the pandemic as well. So if you've joined us, whilst those presentations were going on, we're just going through presentations and then we're doing Q&A. So we're on to our fourth presentation. This one again, completely different. This is talking about introducing social prescribing as a compulsory part of the Imperial College School of Medicine undergraduate medical curriculum. And this is really important, isn't it? Because it's great having lots of people train as doctors, and it's great having social prescribing. But if you don't train the doctors to understand social prescribing, we're going to have a continual misalignment. So let's hear what Smruthy Chakka has got to say. We have to think about today, she's not with us today because she's actually doing a medical exam, so we'll just send our positive vibes to Smruthy as well. But let's hear what she's got to say.
Thank you very much for that introduction. As mentioned, my name is Smruthy and I am one of the social prescribing student champions for Imperial College London. My presentation today is about my experience introducing social prescribing as a compulsory part of the Imperial College undergraduate medical curriculum as part of the lifestyle medicine and prevention module. Before I begin, I'd also like to thank the other social prescribing student champions, Amelia and Amadeep, as well as the Imperial College faculty members, Dr. Bannerman, Dr. Mayle, Dr. Harvey and Dr. Pinder for helping bring this all together. So what is the current problem? As student champions, we knew that social prescribing was an important part of improving health and well-being of patients, and this has been well documented in literature. However, after talking to some of our peers, we realised that we were definitely in the minority of students. Most medical students were completely unaware of what social prescribing is, let alone how to implement it in practice. And this was especially due to the fact that social prescribing is often overlooked in the formal medical curriculum. So we set about thinking about ways to combat this. We came up with many different ideas, including creating social media posts, a social prescribing evening workshop, and perhaps a social prescribing event. However, we felt that the students who would attend these talks and events would be those already interested in social prescribing. And while this would be great, we really wanted to reach those who had never come across it before. So how could we reach more students? We decided that the best way to make sure that all students had at least an awareness of this important concept was by making it compulsory teaching. With the support of teaching fellows and the faculty, we decided to create digital learning resources for the Lifestyle Medicine and Prevention module for Year 2 students in Imperial College. Our aims were to create high-quality learning materials to improve understanding of social prescribing, as well as promote the use of social prescribing amongst these future clinicians. To do this, we designed 3 things. Firstly, a teaching video, then an e-learning activity, and finally, we asked students to design a social prescribing proposal of their own. The first step was the video. This introduced social prescribing and also gave an overview of the current evidence around it. We delved into topics such as the wider determinants of health, as well as the difference between social prescribing and self-care. We also discussed the difficulties in measuring outcomes of social prescribing initiatives and the barriers this caused in the commissioning of these services. We also included a case study illustrating one patient's views, and perhaps most importantly, we discussed how social prescribing actually works in practice. In order to enable active learning and improve recall of these topics, we designed an e-learning activity where students were invited to apply their learning to a clinical scenario involving Joan, an imaginary patient with complex medical and social needs. Students were then assessed on their understanding of factors influencing well-being as well as their practical knowledge of prescribing. Some of the questions that we included were: what are Joan's main clinical issues and how do they impact her daily living? What other factors are impacting Joan's well-being? Would she be a good candidate for social prescribing and why? What could the GP do next? Finally, students were supported to amalgamate all the knowledge they had gained through the digital learning materials and extra reading to design their own social prescribing proposal. They were invited to think as creatively as possible and use any platform they wanted to communicate it. This will later be linked with an in-person session where students will practice signposting to social prescribing as part of a consultation. Despite the COVID-19 pandemic restricting our plans as social prescribing student champions, we adapted to the evolving landscape of medical education and created a permanent digital resource for students. The learning materials we produced form a compulsory part of the module and are accessible during the COVID-19 pandemic. Social prescribing is now firmly embedded in the curriculum for years to come, and as of the spring term in 2021, 360 second-year medical students will have accessed these materials. By ensuring that social prescribing is part of the medical curriculum at Imperial College London, we have made an important step towards pushing forward the social prescribing agenda in the medical school more broadly, but also, importantly, we have introduced this topic to future clinicians. Thank you very much for listening. I've included my email and Twitter handle here if you want to contact me, and I'll now hand back to the co-chairs.
That was fantastic, and I can see there's quite a bit of discussion now starting to happen in the chat box. And somebody said that should be aimed at practice managers, and I wholeheartedly support that. I think there's lots of stuff to do in education of what social prescribing is, and I think this is fired you up, this one has. So that's great. So we've been posting the links to the videos periodically in the chat, and in a few days' time you can come back onto the platform and look at this session, and the links to the videos will be there if you want to pick more stuff up or want to get contact. So our final presentation, and then we'll have a few minutes Q&A, is going over to Portugal. So we've been to Australia, we've been to Ireland, we've been to London and North East England, so now we're going to the Algarve in Portugal, and this is Andrea Silva da Costa, and this is a project that they've been doing over there, understanding the perceptions and awareness of primary health professionals in the tourism region. So let's have a look at that one.
Good afternoon. On behalf of the research team, I would like to thank the opportunity to present our study and congratulate the conference organizers for the event. The social prescribing can be considered as an innovative and creative approach to support and develop the valorization of community structures partnerships. In communities where tourism effect is intensely felt, as is the case of Algarve, the multiple community components are paramount and require integrated approaches. This study aims to assess primary healthcare professionals' perceptions and awareness regarding social prescribing as a first stage of a pilot study that aims to implement and assess adherence and satisfaction regarding an intervention of social prescribing in the context of primary health care in the tourist region of Algarve, Portugal. Concerning senior population, Portugal stands in one of the first places of the population demographic aging, fourth among 27 countries of the European Union with the largest proportion of elderly people. Population aging represents, from the perspective of society in general, and of public health in particular, a victory in the development of conditions that have added more years to life. Concerning social problems, population aging achievements are now, however, a challenge for adapting society and identifying articulated and intersectoral responses. The impact of population aging on society will depend in part on the responses to this new context. Concerning sustainability, how to support an increasingly aging, larger consumer and less financer of social and health system population. Concerning systemic provision, Portugal's national strategy for active and healthy aging aims to promote health and well-being for older people, inclusion, safety and research, to increase their functional capacity, autonomy and quality of life as they grow older. It provides the development of new approaches addressed to clinical and non-clinical needs that enhance the use of existing resources in the community. A cross-sectional study with primary healthcare professionals of the Algarve region was undertaken between July and August 2020. Data collection was performed through an online questionnaire, a Lyme survey platform, self-administration, developed to assess perceptions and awareness related to social prescribing, sent by an email to 300 professionals. Of the 65 health professionals who answered the questionnaire, 66% were between 35 and 64 years old, 72% were nurses, and 27% were medical doctors. More than half of the participants had never heard of the concept of social prescribing. Most of those who had heard about the concept became aware of it mainly through scientific papers. Almost all of the participants agreed with the idea of social prescribing as a useful tool to bring health and well-being benefits to its users, and more than 80% stated that social prescribing could make their practice more effective. The majority considered that it could bring benefits to the functioning of their health unit, and it could bring benefits to the relationship between health professionals and patients. Most of the respondents also agreed that it could bring benefits in terms of social cohesion for the local community. Although the knowledge about social prescribing was only mentioned by few health professionals, the results suggest a global favorable attitude towards the concept and to its implementation. The influence of tourism on community dynamics is widely recognized. Tourism, while accelerating the economy and urban rhythms, implies the spatial coexistence of different populations with divergent interests, with necessary adjustments of public services targeted to the resident population. Thank you all for your attention, and a special thanks to Dr. Mary Polley and Siân, the co-chairs of Research Session 3, Innovation in Social Prescribing.
Fantastic. So those are our 5 presentations that we've got for this session. So there's not lots of questions in the chat, so I'm a little bit surprised about that. But what I'd like to do is invite, if any of our speakers are here, I know I saw Jason and Elizabeth before the session started. Perhaps can you put your cameras on for me so that we can see you? And if Andrea or Caitlin are here, so I've got Elizabeth and Jason, brilliant. You've magically appeared in front of me on my screen, so I'm going to stop spotlighting. So have we got Andrea or Caitlin at all? I wasn't expecting Caitlin from Australia because it's like 3 in the morning there. Andrea, brilliant. Nice to see you there as well. So really, are there questions for these people that people would like to pose? You can either put your hands up or you can put them in the chat, because I haven't seen lots, and I just want to give the audience a chance to ask something before we start asking. And I'm just having a look through, Siân, are you looking through as well? And I know that some have been answered already. Elizabeth, what's your kind of criteria for what a singing group is? I think that was quite an interesting point that someone made. Is it a formal choir, or are you going broader, or what's your search criteria?
Yeah, I think that the term choir can be a little intimidating. There's a formality to it. And so it doesn't have to be a formal choir. We're using terms like singing group or community singing to lend that more informal air. And so the criteria is that there has to be a health or well-being remit as one of the main aims. But that said, we are finding that there are quite a few groups who formed for other purposes, maybe just for social reasons or for as a fun leisure activity. And what they've discovered is that there are these health and well-being benefits that have come to the forefront. And so we're also including any of those groups as well. The idea is to cast as big of a map as possible so that there can be this national resource both for individuals and also individuals who'd be interested in participating in that kind of a group, as well as for prescribers, healthcare professionals.
Brilliant, thank you. I've seen a couple of questions come up for Jason as well. So there's one from Bethany here that there's two, so I'll give you both at the same time. I don't know if you can see them in the chat, Jason. One from Bethany Brown asking, are there any tips to gain funding for secondary care social prescribing? She's from BCSE organisation delivering primary care social prescribing. And are you, Christopher Evans was asking, are you aware of other ambulance-specific social prescribing programmes?
Yeah, great. So Bethany, I'll pick up your question first. For secondary care, I'm assuming you mean funding to support the voluntary and community sector to deliver those programmes. I'm not aware of any direct funding. I'm involved in a funding application at the moment that's looking at potential for social prescribing for CKD patients in secondary care, so people who are receiving hemodialysis. But the funding from that comes from sort of an internal NHS trust application within a single NHS trust. I'm not familiar with any particular schemes, but if there are any that other people know of, please put them in the chat box, because I think that'll be really useful for everyone. And Christopher, other ambulance service specific social prescribing programs. So I come to the sort of social prescribing and ambulance services with quite a unique perspective. So I sit on a national ambulance service group for frequent callers, and we've been discussing probably for the past year, maybe a little longer, about how we can potentially socially prescribe for frequent callers. At the moment, it's done very much on an ad hoc basis with that population, but I do know that some ambulance services have occasionally put in place various different teams. So for instance, North East Ambulance Service at the start of the pandemic put in place a mental health support team where calls could be triaged directly to them or referred directly to that internal team who could then socially prescribe. But there was very little uptake because there was a little awareness of it. So I do know that some ambulance services are doing a little bit here and there, but it's very ad hoc. It's very much based on what's available in local CCGs. But ambulance services deliver across much larger catchments of CCGs. So there's a big issue about how we join that up and create sort of a single programme within services. And we are trying to look for, quite frankly, some funding with discussions with NHS Digital, the likes, to try and pilot this properly. So it's perhaps a bit of a watch this space. But if things do develop, then that's fantastic, if they do develop naturally.
Brilliant, thank you. I think there's quite a few questions coming in for you, Jason, because I think people in different parts of the country are interested in perhaps connecting. I saw Susie there from HRP in London putting some comments in there as well. And Somebody said, I'm wondering if there's scope for this research to be applied to other emergency services. I know that the fire service do a safe and well visit, and in many areas they then, if they pick up loneliness or they're concerned about the state of someone's house, they refer into social prescribing schemes. But I don't know much about police and social prescribing. Sean, do you know any police schemes that are socially prescribing?
What I do know is schemes that have co-designed and co-produced from the outset with their communities, like Frome, and there was a model in Essex at one point. They train all of those people that are normally having contact with the public to signpost to activities, to understand the benefits of asset-based, strength-based approaches, and to know what's in the community. If they're complex, then yes, they would refer directly into social prescribing link workers who can spend more time with people. But that really is a model that's system-wide to try and avoid that dependency on the primary care. You have to see a GP or go to a GP practice to access social prescribing. So it becomes this interconnected system-wide approach to social prescribing. So yes, I've seen it where all types of services. So the one that I worked on in Essex, we trained over 600 people within about 40 different organisations that already had contact with the public. And I know Frome have done over 1,000 training sessions with businesses as well. So this really is about social prescribing being for everyone, but by everyone. So it's that mutual responsibility of community. So yeah, there are models around that are embracing that wider approach now.
Brilliant. Now, someone's put their hand up. Oh, okay. Carolyn Biggs, do you want to ask your question? You've got your hand up.
Yeah, I had a couple of questions for Jason. So my question was about the time between like receiving a referral and like the actual intervention. So is it kind of quite swift or is it quite kind of rapid? And then the second part of that was, is there any way that you kind of prevent any duplication? Because often the complex, like reoccurring patients that are ringing a lot, I know from like our UCR team, they've often got a lot of other external workers sort of working with them as well. So I just wondered with those two kind of questions.
Okay, I'm trying to think where to start with answering these. I think those questions are perhaps a little bit further down the line, in that the project that we did here was simply about looking at the potential for social prescribing. As I said beforehand, it is done a little bit, but at the moment there's no formalised process for doing so. It's something that's very difficult to do within the current setting, without simply just referring people back to primary care. So I suppose essentially the way that I would see it is that as we go forward and we develop possibly new models of care here, it's about identifying the multiple different pathways to try and avoid that duplication, as you say. So it may be that paramedics who are attending on scene might be able to socially prescribe, people within clinical hubs, it might even be non-clinical call handlers. All of those may well socially prescribe. Alternatively, it might just be that the best model is to refer people back into primary care. Until we really start testing this, we don't know the answer. I suspect referral back to primary care is not the answer, because people are accessing ambulance services for a primary care problem for some specific reason. It might be unable to access GPs or whatever. So I suspect that won't be the approach, but we don't actually know what the best approach is yet.
Thanks very much, Jason. I want to have a chat with Andrea from Portugal, and welcome and thank you for joining us. And it's really interesting to see how you are developing the awareness of social prescribing in Portugal. Obviously, it's been a really tough year in the UK for us, an island. I wonder how it's been in Portugal, and has that affected people's or GP and nurses' appetite for social prescribing? Has that changed things for your research?
Hello, thank you for your question, and thank you again for having me here. It's a great pleasure. we found out in our research is that some health professionals recognize that most of their patients are willing to adhere in the future, which was interesting because in the first, one of our questions was if they knew already about social prescribing, and it was surprising for at least some of us in the research.
We're just starting to have a little bit of...
Because, as you know, Algarve has from UK, and we thought maybe this region has already more. Oh, sorry. I think my internet was with some issues. Maybe you can hear me now.
It's a little bit patchy, but just carry on, and we'll see if we can persevere.
So I was saying that we thought that maybe the concept was already in the community. Sorry. I think
That's a shame. I think we've lost her there, haven't we?
She's it's gone offline. I'm really sorry, Andrea. That is such a shame.
I'm sorry.
Oh, are you there again? We can hear you now.
So can you hear me now?
Yes.
Okay, thank you. So I was saying that we thought maybe because we had many residents from UK, different answers from the health professionals in Algarve. And we heard that the most health professionals, the knowledge that they had was from scientific papers. So it was from the connected community that they had. But we were also surprised because they were so much available to collaborate with us, and also they said that many times they had really want to had an element of advisor to non-clinical needs.
I think we've just about I'm pretty sure I got what you said there, Andrew. Thank you very much for persevering with that Wi-Fi connection. So I think it's quite interesting because in England or the UK and other countries, a lot of the development of social prescribing has been by professionals. And I noticed some stuff about discussion on the term social prescribing in the chat. And there hasn't been so much work done to educate the public yet, mainly because social prescribing as an architecture and structure hasn't really been properly in place, so it feels wrong to tell the public about lots of this when actually there isn't so much of it there. Although we've been out on the BBC and on TV earlier on this year on 2 programmes that have had quite high viewing figures. So word is starting to get out. So it's interesting to hear that the GPs and the health professionals have learnt about it through the publications and the reports, not through the tourists that they're treating that are coming to that region, because obviously you do have quite a lot of British tourists over in the Algarve. So interesting to hear how things connect up, isn't it? So we've got 5 minutes left. Sean, are there any other areas, questions that you've seen that we've not covered?
So there's a couple of queries from people wanting to speak to Caitlin in Australia and Smruthy, but we've said before that Smruthy has a medical exam today, so unfortunately she can't be with us. And I think the time difference for Australia is just not doable for today, but please do look again at the links for the Vimeo recordings that are in the chat box. Take a note of them, copy and paste them today. You can go back, look at the slides, look at the recordings again, and their contact details are in all of those. So please do make contact with them. I'm sure they would be delighted to hear that you've listened to their recordings today. Lots of chat around the community approaches and whole system approaches, not just around police and ambulance, but other services as well. So this really is about how we embrace whole system social prescribing. This shouldn't be about solely a primary care model. We are really fortunate in this country to have primary care on board and the fantastic resources that have come with that. But we really now need to get back to the basics of what matters to community and how we engage all partners, all people working, living and behaving in communities to link together, to connect to those strengths, resources and assets.
Absolutely. And I think it's worth saying as well, primary care link workers were few and far between when the social prescribing movement started. It was local authority and VCSE funded link workers and hosted link workers. And as as popularity has gained and we've got the 10-year forward view plan and all of that, and it gets talked a lot about it being an NHS thing, but really it isn't. It's a complete mixture. And if you do any surveys in the UK, you'll find there are as many link workers in local authority hosted services and VCSE hosted services and broker organisations as there are in the NHS. So, and there's pros and cons with all of that.
And I think what I'd encourage, Marie, is, most of our audience here today is from the UK, but however, there are some amazing models of social prescribing internationally. We've had some amazing talks, some innovation, lots of poster presentations. We're building those relationships now through the network. And, if you look at some of the models of social prescribing internationally, it's those guiding key principles of connection, of community, ABCD, asset-based, strength-based, that are replicated across the globe, and some fantastic examples. So it might be that you cast your net wider to look at those examples, and bring them closer to home.
Yeah, great point, Siân, because at the afternoon, tomorrow afternoon, we have Kate Mulligan keynoting for us. I saw Kate was in this meeting, and she'll be talking about the work from a Canadian perspective, but we'll also be hearing from the US, from Portugal, Ireland, and the Pacific region, from Singapore and Korea and China. So it is interesting to see how people are doing it. Also, if you do want to connect with the speakers, you can send messages via the attendee list. And if someone's not registered, like Smruthy hasn't registered yet, you can still leave a message for her and we'll tell her to pick it up off the platform afterwards. So I think we're just coming up to 3 o'clock. I'm really excited because the Social Prescribing Awards are at 3:30. So I do hope you can come to those. But I'd really like to say a big thank you to Elizabeth and to Jason. Andrea, we had Caitlin and Smruthy for sharing their research with us, and I hope that there's been some other connections made and that has furthered on your research and your ideas and everything. So thank you very much. Siân, you've got the final word.
So yeah, just to echo those thanks, amazing innovations and research there. We really look forward to seeing those reports, reading and digging into them. Do go to the awards now, and thanks Marie and speakers again.